of Maternal and Child Health. She has numerous research papers, one of them being the incidence of cervical dysplasia in Bahamian females using Depo-Provera. And one of her publications is the prevalence of cervical cytology abnormalities and HPV in women infected with the HIV virus. Her hobbies and interests: she's a fitness enthusiast, a chorale singer, and she enjoys getting involved with volunteer work. She is also married and the mother of two beautiful children, Ethan and Gabrielle. Dr. Griffith-Bowe, thank you for joining us today, and we look forward to your presentation. To our audience, you can place your questions in the chat or raise your hand, and we will unmute you at the end. Thank you very much.
Thank you. Thank you, Dr. Black, for that kind and thorough introduction. Before we get started, can everyone hear me well, see the slides? And is everyone ready to go?
So we can hear you and we can see you.
Okay, awesome. Is it customary that we pray before we start the meetings or no?
You can if you would like.
Okay, great. So Heavenly Father, I just thank you for bringing us together to learn and to spend an hour just being with each other and learning about this issue that can affect our patients. We pray that the knowledge that we gain today, that we will be able to use this knowledge going forward to assist our patients further. This we ask in the name of your Son. Okay, so let's get started. So I am so very happy to be here, and I'm so happy to see you guys up this early in the morning to talk about this topic that is very special to my heart, the menopause. Now, this topic is so extensive that initially I thought that I would have been able to discuss a practical approach to menopause on the whole, but then when I realized the extent of the topic, I decided that perhaps I ought to focus a little bit more on the controversies that exist with respect to the hormonal therapy. So let's get started. Okay, so first of all, we will start with our definition. So what is menopause? So menopause refers to the permanent cessation of menstrual cycles, menstrual periods. It is actually a diagnosis that is made retrospectively after an entire 12 months of amenorrhea. And we also note that natural menopause occurs in the absence of any other obvious pathology or physiological choices or physiological causes. So we know that menopause typically, can you see my pointer, Amala? Can you guys see my pointer?
Yes, we can.
Okay, yes, we
awesome.
can.
Good, thank you. So we know that the average age of, or the median age of menopause is about 51.5 years old, but generally speaking, menopause occurs typically between the 45th to the 55th year, and it really reflects a complete or near complete ovarian follicular depletion, and this results in substantively low estrogen levels and higher follicular stimulating hormone levels. And as you can see from this graph that I borrowed, we can see that as the individual's age, that the number of ovarian follicles substantively depletes to almost complete depletion. So this is very, very significant of menopause. So to be honest with you, we have completely confused ourselves. We have confused our patients. We have confused our med students with many of the vague and overlapping terms that we have been used to define female reproductive aging. We have used premenopause, perimenopause, climacteric, and sometimes even I get confused. But there is a workshop that was convened by the Stages of Reproductive Aging, and they convened a workshop to develop a system for staging spontaneous natural menopause. And so it helps to take away some of the ambiguity that we have seen over the years. And so when you look at the straw staging of female reproductive aging, we note that the anchor is the final menstrual period. So the entire process is considered to, well, it's anchored from stage 0, which is the which is the final menstrual period. And then we look at the menopausal transition, which is divided into 2 stages, the early and the late stage. And then we look at the postmenopausal area and transition, which is defined again into 2 stages, the early and the late stage. So essentially speaking, the language used to describe menopause, I think, is simplified if you consider it to be the menopausal transition prior to the onset of that final menstrual period, and then the postmenopausal era that starts a year after the final menstrual period. The interesting thing is that the late menopause, it begins at the end of the early menopause, and it literally has definite possibilities because it ends with death. So if you guys have any questions, feel free to stop me and ask. So when we look at the straw staging, we note that the early menopausal transition, during that transition, one notes that there is a change in the intermenstrual interval. So cycles get a little bit unpredictable. They may be further apart, or they may sometimes occur closer together. So this occurs in the early menopausal transition. When we look at the late menopausal transition, this period of time, it can last about 1 to 3 years and is more associated with skip cycles. So this period is essentially substantively closer to that last menstrual period and is associated more prominently so with skip cycles and longer periods of amenorrhea. And of course, the postmenopausal is very distinct because there's a sustained amenorrhea, i.e. the complete cessation of menses. And of note, during this stage, one would expect substantively high levels of follicle stimulating hormone, and conversely, extremely low levels of, considerably low levels of serum estradiol. One would also note that during this stage, either during the early transition, the late transition, and the postmenopausal stage, there are also some other endocrine changes that are typical of the menopausal era. One would note that there is substantively diminished serum inhibin B. You can also find substantively diminished anti-Müllerian hormone. These are both products of the ovaries granulosa cells. And on ultrasounds, one may find ultrasound studies may demonstrate a decline in the ovarian follicular count. But please be very, very cautious. Note that those additional hormones that I spoke of, the anti-Müllerian hormone, the follicular stimulating hormone that I mentioned before, and using the antral follicular counts and estradiol, these are not studied in the setting of diagnosis of menopause. Preferably, these are used in the setting for assisted reproductive techniques. Inhibin B, and my oncologist colleague would agree, is typically measured as a diagnostic evaluation for ovarian tumors, but not for the evaluation of menopause. So it is important, and I mentioned that here, and I will mention it again, that even though we know that there are distinct endocrine changes that occur around the time of menopause, whether in the early, the late transition, or the postmenopausal era, that these hormonal changes, these endocrine changes are not used for diagnostic purposes. So let's look at the symptomatology of menopause. My good doctor, why do I feel as I do? The interesting thing is that the process of the menopause can affect every organ system, both in the long and in the short term. One would note that there can be substantive vasomotor symptoms, i.e. hot or cold flushes. There can be sleep disturbances. There can be mood swings. You can have issues with the genitourinary system, cognitive decline, low sexual desire, and joint and muscle pain. When we look at the vasomotor symptoms, we would note that this is the most common symptom during the menopausal transition, and approximately up to about 80% of females may experience these hot flushes, and when they occur in the night, they will be experienced as a night sweat, right? So hot flushes typically it's just a sudden sensation of heat, and it's centered in the upper body, centered in the face and the chest, but then it can rapidly become generalized. It can last for a few seconds to up to about 4 to 5 minutes. It can be associated with, It can be associated with profuse perspiration, occasional palpitations, and sometimes one can have the chills and shivering and a feeling of immense anxiety. The thing is, one would think that, or the traditional thinking was that the hot flushes got less and less and less as the females traverse the menopausal transition into the postmenopausal era. But studies show that these hot flushes continue for as long as 20 years after that final menstrual period. It's important to note, though, that the recognition or the importance or the rapidity with which hot flushes are reported, it is largely influenced by racial, ethnic, and cultural perceptions. And so you may find that some ethnicities or some cultures handle these incidences of these hot flushes and report these incidences of hot flushes to their physician way more readily than others. When we consider the sleep disturbances can also be a considerable symptom of the menopause, and it can occur in up to 50% of females. It may be predicated and complicated by night sweats, but primary sleep disorders are also a common symptom of the menopause. When you consider the issues of the mood swings and the irritability and depression and the melancholy, these are also substantive symptoms and can also contribute to the lack of sleep that can occur in women during the menopause. When we look for a moment at the genitourinary syndrome of menopause, so this is typically what we remember being taught of as atrophic vaginitis and vulvovaginal atrophy, but the name has been changed so that it can be brought more attention to what is happening down there to women during the menopausal area. And it's all because of the hypoestrogenic changes to the labia, to the clitoris, to the vagina, and to the urethra, as well as to the bladder. And in general, these symptoms tend to occur a lot later than do the hot flushes or hot flashes. And the estrogen deficiency leads to a substantive decrease in blood flow to the genital area and to the urinary tract. And so these areas are more prone to infection. The skin and the vulval mucosa may be intrinsically thin, easily bruised, and could easily be irritated even from day-to-day movements. And so it can be quite an uncomfortable condition. Indeed, we do recognize that low sexual desire is also a symptomatology of menopause, as is joint and muscle pain. So let's consider the consequences of menopause. What can a woman anticipate on a long-term basis? So as we understood from my previous discussion, menopause, during menopause, ovarian estradiol substantively decreases. However, we know that testosterone production continues to increase. And so this is one of the factors that contribute significantly to the long-term manifestations of reproductive aging. And so we know that osteoporosis, characterized by a low bone mass and thus increased fragility of bone, occurs. And we note that osteoporosis can affect a substantive numbers of women, such that up to 50% of postmenopausal women can endure an osteoporotic fracture. And these can more commonly occur in the hip, in the lower vertebra, and a Colles fracture. So we understand that the estrogen deficiency of menopause results in excessive bone resorption in an environment of inadequate bone formation. So we understand thus that estrogen deficiency leads to an increased number of osteoclasts, and this subsequently causes more bone resorption, while the osteoblastic numbers decrease, and thus there's less bone formation. So we define osteoporosis in the postmenopausal group as a T-score of less than 2.5, and in the presence of an osteoporotic fracture and a T-score of less than 2.5, then this is considered to be severe osteoporosis and would require treatment. So when we look at cardiovascular disease, we know that before the menopause in women, the risk of cardiovascular disease, it lags behind the same cardiovascular risk for men by as much as 10 years. But after the menopause, there's a rapid catch up, and a woman's risk for death due to cardiovascular disease increases significantly. So we know that estrogen adequacy favors a reduced LDL and an increased HDL, but the reverse is seen in the postmenopausal women. I mean, studies do suggest that the protective effects of estrogen may not simply be related to a more favorable lipid profile, but may also be related to some intrinsic endothelial factors as well, like enhanced endothelial healing. And so with the altered estrogen at menopause, we still can't quite explain all of the factors that may lead to an increased risk of cardiovascular disease. But we know that women are at substantive risk of heart attacks and so forth as they age, as a process of reproductive aging. And of course, not necessarily detrimental, but disturbing is the changes that can occur in body composition. Women tend to gain weight, especially centrally. Skin becomes thin and wrinkled. There's an issue with balance, and if women fall, then that puts them at a greater chance of getting an osteoporotic fracture. And of course, the dementia that can occur as the process of reproductive aging. I think we will have discussed all of this already, so we'll just quickly skip through it. So is everyone still awake? No one has left.
Yes, we are.
No one has left the building. Okay, good. We're all still awake. Awesome. So let's continue. So let's look at the diagnosis of menopause. And remember, I told you before that there are lots of endocrine changes that occur during that early and late menopausal transition and the early and late postmenopausal time span. There are lots of hormonal changes, but those hormonal changes aren't tested and studied and used for the diagnosis of menopause. And so we must remember to resist the urge to perform unnecessary investigations. Please pardon this slide. I know it's extremely busy, but I took this directly from the NICE guidelines because I wanted us to look at this and give it the value that it deserves. The NICE guideline says that the diagnosis of menopause, perimenopause, when it speaks to the diagnosis of perimenopause and menopause, we can do so without laboratory testing in otherwise healthy women over age 45 with menopausal symptoms. So you can make a diagnosis of perimenopause, or remember that term has now been changed to either the early or the late menopausal transition. So you can make a diagnosis of the early or late menopausal transition simply based on the symptomatology, for example, the vasomotor symptoms or the presence of irregular periods. Similarly, you can make a diagnosis of menopause in women who have not had a period for the last 12 months and are not using hormonal contraception. Naturally, if an individual is using hormonal contraceptions, it could be difficult to determine precisely when that last or when that final menstrual period occurred. And of course, you can make a diagnosis of menopause based entirely on symptoms in women without a uterus. So it's really, really important for us to put down those pens and not rush to order that FSH and estradiol levels in 2 consecutive months or 28 days apart, because it really isn't necessary. And again, NICE guidelines, again, stipulating what I just said, do not use this laboratory testing to diagnose menopause in women over age 45. And just for completion, I'll read it: the anti-Müllerian hormone, the inhibins, estradiol, the antral follicle count, and ovarian volume, which are all determined via ultrasound. So again, these are used in the setting of either oncology or in the setting of an infertility workup, but not for the diagnosis of menopause. Okay, you can, however, feel free to consider using the FSH levels in women who experience these symptoms at an earlier than expected age. So women with symptoms suggestive of menopause who may either be between 40 to 45 years or even younger than 40, by all means proceed, and you can do the specific testing on these ladies. Okay, so I wanted to take a minute to look at the management of menopause. And for us to be able to consider the management of menopause, we have to delve into some controversial subjects, some controversial issues, some things that happened in the 20th century that we need to openly discuss. So I will diverge for a minute and try to set the stage for the entire controversy that has arisen over the treatment modalities that are available for menopause. So this picture shows a gynecologist. His name is Dr. Robert Wilson, and he published a best-selling book. The name of it was Feminine Forever. And interestingly, in this book, he maintained that menopause was a malediction. It was a curse, right? Basically, that was an estrogen deficient disease that should be treated with estrogen replacement therapy. And he described the menopause as an inevitable living decay. So Dr. Wilson claimed that additionally that he was the original discoverer of the estrogen therapy, and that he also discovered or proposed the sequential estrogen progestin cyclical therapy as well in the menopause, neither of which have been proven to be true. Dr. Wilson maintained that femininity, both physical and emotional, was determined simply by and only by the amount of estrogen that was in a woman's body, and that estrogen therapy, therefore, can increase femininity in young women. It can preserve it in middle-aged women, and more importantly, it can restore it in aged women. So essentially, his book really emphasized the use of hormone therapy throughout the lifespan of women. And it spoke about the importance in the life. It spoke about the sexuality of women throughout her life, and suggested that the woman's sexuality was not only crucial to her psychological fulfillment, but also one crucial test of a woman's adequate sexuality was her ability to find a suitable mate. One of his amazing quotes was, menopause is a hormone deficiency disease. It's a hormone deficiency disease, not a process of aging. It's a disease which is curable and totally preventable. Just take estrogen. So naturally, this caused some heated discussions, and this actually promoted the whole, this gave the feminists and the feminist movement a stronger voice. And even though in the late 1900s, even though even though all the women did not respond with one voice, meaning some agreed and some didn't agree, there was a substantive challenge to the words spoken by the good gynecologist. And women began to speak out more for themselves, and began to participate more in decision-making regards to their own health, in controlling their own bodies. So when we look at this entire discussion of the management of menopause, we have to look at what transpired over the last 100 years or so. And so because there was so much interest in the use of hormone therapy, naturally, there were several substantive studies that were done in the 1900s as individuals use more hormones throughout the course of their lives, then more information was available to be critiqued. And so in 1975, there was a link that was established between endometrial cancer and unopposed estrogen. In 1994, the menopause study discovered, however, that lower dosages of estrogen, one second, please. Of 1992, which specifically sought to see if using hormone replacement therapy, if that substantively diminished or decreased the risk of coronary artery disease in aging women, and that was not discovered to be true. And then, of course, my med students and my residents would have heard and read and probably know every aspect of the Women's Health Initiative Group. And the Women's Health Initiative Group was indeed a massive, massive study. The group itself was designed to investigate the major mortality and morbidity factors that occur in women as we age, and how these factors can be influenced by hormonal therapy. And so when this study was envisioned, it sought to discover whether hormone therapy, whether it can truly reverse the aging process, and if hormonal therapy indeed offered any protection at all from heart disease. And so when you look at the literature, or when you even do a Google search, these are some of the studies that immediately come to your page. And these are some of the studies that created so much discussion and controversy over the years as we spoke about the menopause. So the Women's Health Initiative study, actually, it had 3 arms. It had an estrogen and a progestin arm, or combination arm. It had an estrogen only arm. And then it had an arm that looked specifically at it was the Women's Health Initiative memory trial to see if the use of hormone replacement therapy, if it had any factors at all to play in the cognitive decline, in reversing the cognitive decline in women. And so seem to be stuck for a minute. Okay, good. And so the WHI, the women's trial, utilized almost 17,000 women, but these women varied in age from 50 to 79. I think that's very, very important, because these women were substantively older. Remember, I told you that women typically experience the menopause between the ages of 45 and 55. The median age of women in these WHI trials was 63 to 64 years of age. So immediately, your ears can perk up, because think about it. So why are we studying the use of hormone replacement therapy in women that are indeed so beyond, so late into their postmenopausal period, and thus may be susceptible to some of the conditions that were reported? So very briefly, there is no surprise, really, now that we can look back and think about it retrospectively. There was no real surprise that the trials had to be stopped early. The trial that used a combination of estrogen and medroxyprogesterone, it was found to have an increased incidence of coronary artery disease, almost 30% in these older women, an increased incidence of stroke. They also found an increased incidence of thromboembolic phenomena. They did find an increased incidence of breast cancer, which was reported over and over and repeated over and over in the media. But to be perfectly honest, this increased incidence was not statistically significant. It really accounted to an increase globally of perhaps 1 additional case of breast cancer in 5,000 women. We did note, however, that there was a decrease in colon cancer incidences and decrease in fracture in individuals who received the combination therapy. And in contrast, when we looked at the estrogen-only arm of the WHI trials, the Women's Health Initiative trials, they found no significant effect on coronary artery disease. So there was no increased effect on coronary artery disease when estrogen alone was used. There was a slight increase, there was a maintained increase in strokes and thromboembolic phenomena when estrogen was used only compared to placebo. But substantively, there was no increase in the breast cancer incidence. There was no significant decrease in the colon cancer incidence. And the positive effect on osteoporotic fractures was maintained. So with all of that came the FDA warnings. And it's not surprising that with the discussion from the gynecologists, the responses from the feminist groups, the skewed reporting of these trials in the media stating that estrogen and progestin cause an increased risk in breast cancer and strokes and heart disease, but not mentioning that these women were substantively older and we're probably more prone to these conditions in the first place. So the FDA then had to step in, and they issued several warnings that indeed stipulated the way that we use hormone replacement therapy today. And so we now look at the treatment for menopause in terms of the individual's specific complaint. So menopause is not a malediction, it's not a curse, it's not a disease, it's a consequence of aging. And so the interventions that we provide as physicians have to be symptom specific. So we're not going to use estrogen therapies to maintain supple skin and nice hair, and just to maintain a feeling of well-being. There are very, very specific indications for the use of hormonal replacement therapy in this age group. And what we also learned from these trials is that we must use the lowest possible dose of these hormones for the shortest possible time. So typically we aim to use these methods for perhaps as much as maybe 3 to 5 years. And then if necessary, we reassess. So here we go again, taking flight. Is everybody still with me? At least one person still with me?
Yes, we are. We are.
Awesome. So now let's look at the actual treatment. So here is where the meat of the matter is. So remember, I did say that the vasomotor symptoms were the most common symptom of menopause, and that was seen in about 80% of women, right? And so despite the fact that it's most common and it's seen in about 80% of women, it is probably one of the least reported symptoms. So if you want to know if this is happening to your patient, you will have to ask. Okay, so as for the FDA recommendations, we now understand clearly that we can use hormone replacement therapy and safely for the purpose of treating the vasomotor symptoms, the hot flashes, the night sweats, right? So we understand that we can use estrogens alone in women without a uterus. So in hysterectomized women, we can use estrogen alone. And in women with a uterus, we need to use a combination of either continuous or cyclical progestin with the estrogen for endometrial protection. However, we must acknowledge that we have to have a full and open discussion with the risks and benefits. The fact that short-term use is preferred, and we are going to start at the lowest effective dose. So guess what? The reason why I took the time to go through that whole conversation about the physician and the discussion of menopause being a disease and a curse, and all of the studies that followed, or some of the important studies that followed, is so that going forward, we can have a more fruitful and meaningful discussion with our clients, because trust me, they're reading Google, so they're seeing those references as well. So just to remind us, the first line therapy for the vasomotor symptoms is systemic hormonal therapy, whether it be estrogens alone or a combination of estrogens and progestin. And there are so many choices out there. There's so many choices that are available. In country, we might have a challenge, but my good pharmacist, Mrs. Dean, who is on the call now, as per the other pharmacists, are always willing to source a medication if asked. So when we look at the estrogen alone therapies in country, definitely we have Premarin. Now I know for sure that we have the Premarin at the 0.65 dose, and so I tell patients, well, try to break it in half, use a pill cutter and break it in half. But we have multiple choices to deliver this medication. We can use estrogen patch. We can use the estrogen patch. And to my knowledge, we can source the Vivelle dot and the Vivelle. We also have available the transdermal gels that can be ordered. But of course, when you consider special ordering meds, there can be a substantive cost. But the important thing is that you can allow your patient to know that if she needs to use hormonal therapy, then she can get it in the form of a pill. She can get it in the form of a patch. She can apply a gel, a spray, or even the vaginal ring. And take a look at the cost of that vaginal ring. $355. When we look at the combination therapy, the combinations of estrogen and progestin, for sure, in country, we have Angelique. We say that for sure, that we have Angelique. But you can have the oral packs with the combination, and you also have the transdermal patches as well with the combination. I would say be cautious, because if there is a history, if your patient has a history of previous thromboembolic disease, undiagnosed breast mass, or history of breast cancer, or undiagnosed vaginal bleeding, I would be very hesitant to offer these females hormone replacement therapy. For these patients, you now have to consider the approved non-hormonal therapy. So you have to consider for these patients that it's safer for them to use the non-hormonal therapy, which may not be as efficacious, but definitely would have a lower risk profile in their scenarios. So what are these second line therapies? So as I said, these are not as effective as the hormonal therapy. And the fact of the matter is that side effects may limit their use, but we do have second line therapies available. And they include the Paxil, the SSRI, the Paxil, rosatine. This also includes the serotonin norepinephrine reuptake inhibitors, and we would all be familiar with these as antidepressants. Okay, so this is Pristiq. We can also utilize the anticonvulsants, the gabapentin, and the antihypertensive clonidine. Now, of course, you're going to have that conversation, because these therapies do come, as I said, with their side effects. The SSRIs, they're about 2/3 as effective as the hormonal therapy. And this is also similar for the anticonvulsant gabapentin. The clonidine is not as effective. It has a similar, so the clonidine has a significant but substantively smaller effectivity in terms of reducing the vasomotor symptoms. And you do have to talk about the possibility of nausea and nervousness, somnolence and dizziness and dry mouth and drowsiness. But these therapies are available. The SSRIs and the SNRSIs and the anticonvulsants are effective, not as effective as the hormonal methods, but at least you can offer the patient some form of therapy. And so this table was taken from ACOG. There was an error that was corrected and stating that yes, the SSRIs are approved for the management of non-hormonal symptoms. I just made the correction on the slide, so that's why this looks like this. And I use this slide specifically because I wanted to point out something that we are going to discuss very, very shortly, in that when you consider some of the alternative methods, that there really may not be any evidence that these are beneficial for the treatment of the vasomotor symptoms of the menopause. So let's delve into this controversial issue right now. So what does the data say about the alternative therapies? And as I said, despite the widespread use of these products, at best, the data is conflicting. It is anecdotal information, and it's observational studies that really lack the regard to suggest that there truly are globally across the board effective for treating the vasomotor symptoms. But let's look at each category in turn. I know that this is of interest to everyone in this chat room, because our patients would prefer to use a modality that is termed natural as opposed to the traditional medication. And really and truly, considering the mess that we made of the use of hormone therapy in the past, then can we blame them? So when we look at some of the alternative therapies, let's start with the bioidentical hormones. Now, these two are not FDA approved. They're typically plant-derived and are either identical or structurally similar to the natural hormone itself. The problem is because they're not rigorously tested, there's variable safety, there's variable efficacy, purity, and viability. When we look at the phytoestrogens, the herbals, and the vitamins, these two are considered to be supplements. And so they are not subjected to the rigorous standards of testing and regulation that is typical of standard therapies. Okay. Furthermore, studies may even use different endpoints of treatment that are not consistent across the board. So comparing one to the other could be quite difficult. Now, we know that the phytoestrogens, the isoflavones, and the lignans, these spark immense interest because Asian women with diets high in soy report substantively less vasomotor symptoms. But yet, the evidence is insufficient, and Cochrane meta-analysis up to this point has shown no concrete benefit throughout. Okay, and the issue is that we might have some toxicity factors, as has been seen with the black cohosh, where there is some reports of liver toxicity. So the major concern is that these phytoestrogens and these herbals may have deleterious effects, unwanted side effects, unwanted interactions, but yet no proven pharmacological benefits. Okay, we do know that there may be some marginal reduction of symptoms with the use of vitamins E and C, but again, the evidence for this is inconsistent. When we look at the alternative techniques, for example, acupuncture, reflexology, magnetism, now again, there's no significant proven benefit. Now these techniques may very well make us feel relaxed, make us feel renewed, and make us feel substantively better in other ways. But can we literally prove that they have decreased in long term the number of hot flashes? No. What we have seen is that stellate ganglion blockade is showing some substantive promise, and so this is actually the one to watch, the stellate ganglion blockade. And so again, I repeat this slide. I'm just giving you the evidence. I know that there are probably lots of persons on this chat room who use these alternate therapies themselves and who can say that they themselves have seen some benefits and that their patients have anecdotally told them that they have been benefits. But we have to, as physicians, look at the evidence, and we have to speak from that point of evidence. So my final points on but it is indeed an individual decision, but my final take-home point is that these are not FDA approved, and there's substantive lack of evidence of benefit. So moving sweetly along now, we're getting close to the end, moving sweetly along, have a few more minutes, moving sweetly along to the management of the genitourinary syndrome, which is substantively important to women. We can start with the vaginal lubricants. We can use the lubricants and we can use moisturizers. We can try these first and see if the woman feels substantively better. And if there is still considerable complaints or issues with intercourse, then we can try our hormonal therapy. Now, vaginal symptoms are exquisitely responsive to vaginal estrogen. And the good thing about vaginal estrogen is that we can apply it in very low doses with very minimal to nil systemic absorption. So we can start the vaginal estrogens on a daily basis, and then we can proceed on a every other day basis for as long as is required. My apologies. Getting some feedback. So, so let me get my train of thought again. Right. So there's very little absorption of topically applied estrogen, and so we can safely and comfortably use topical estrogens, vaginally placed estrogens, without the need for monitoring of the endometrial thickness. A relatively new and exciting modality that is also FDA approved for the vaginal atrophy is Osphena. So Osphena is a novel estrogen, a serum, an agonist and antagonist. And so during the clinical trials, it was proven to be effective for vaginal, for the vaginal atrophic changes. And so it has been approved, it is FDA approved, and it is the only serum that is approved for the management of the genitourinary syndrome of menopause. The only serum. Tamoxifen is not approved for this use, okay? The other thing with Osphena, unfortunately, is that it is a bit cost prohibitive. My pharmacist, Gina, has advised me that it may cost you $1,100 for a box of 90. And they're used once daily. Okay, so this chart just shows us the options that are available for hormone replacement therapy for the genitourinary syndrome. And as you can see, we have the vaginal or local creams. We have the ring that we can use. I did mention the lubricants and the moisturizers. And of course, in the rare case that the patient is still terribly discomforted, despite the fact that the vaginal hormones are used, then you can use the systemic therapy, of course, starting with the low dose and the ultra low dose options, always avoiding the systemic therapy where possible. So let's just look and summarize the clinical, the key points, the clinical recommendations with respect to hormone replacement therapy. And these are the things that we want to remember. And these are the things that I want you to take home and be able to take back to your office and be able to discuss with your patients. Combine estrogen and progestin therapy, but not estrogen alone. From the studies that we discussed, was found to increase the risk of breast cancer. But the risk is limited to that use beyond 5 years, okay? So just be very, very cautious. We can use the combination therapy, but remember the lowest dose for the shortest period of time. When we look at the systemic estrogen alone or in combination with the progestin, again, this is the most effective method for the hot flashes, and this is FDA approved. Again, because of the potential risk with longer term use of hormonal therapy, please let us use the lowest effective dose for the shortest period of time. Again, there's no high risk consistent data that the black cohosh, the omega products, the botanical products, and the lifestyle modifications improves hot flashes. The decision to continue combined hormone therapy for more than 3 to 5 years must be made after reviewing the patient's risks and benefits and after having a thorough discussion with the patient. And we did discuss the use of non-hormonal therapies for the genitourinary syndrome, including the use of vaginal moisturizers, as well as the new serum, Osphena. Okay, so guess what? We're almost home. We're almost home. So I just wanted us to just take a quick peek at the long-term benefits as opposed to the risk of the hormone replacement therapy. So we spoke about the risk of venous thromboembolism. We spoke about the fact that this is increased in using the hormonal replacement therapy, as was demonstrated by the studies. So this is something that needs to be discussed with your patients. We discussed that the systemic therapy is associated also with a small increased risk of strokes, but again, the non-systemic therapy, the transdermal, etc., did not demonstrate this increased risk of stroke. We also discussed that the hormonal replacement therapy does not increase the risk of cardiovascular disease when used in women under 60, and neither does it positively affect the risk of dying from heart disease. So indeed, the premise by the good gynecologist that suggested that estrogen therapy could improve the cognitive decline in women, that was refuted. And the fact that we now know that hormone replacement therapy, when used under the age of 60, does not increase the risk of heart disease is substantive, because the clinical trials that I discussed previously, remember I did tell you that there was a substantive increase in heart disease, but guess what? These ladies were considerably older. They were perhaps between the age of 63 and 64. So hopefully our patients who would be requiring these therapies would be within that menopausal age group, between the ages of 45 and 55. And so you would not have to be that terribly concerned about increasing the risk of heart disease. So when we look at the long-term benefits as it relates to breast cancer, from the studies as well, it did state that the hormone replacement therapy with estrogen alone was not associated with any risk of breast cancer. However, we did note that when estrogen was combined with progestin, there was an associated risk of breast cancer. Now, the evidence around this, or the explanation for this, is kind of unclear. We're not really sure if the combination was responsible for inducing de novo breast cancer, or if it was responsible for revealing the occult breast cancer. So this is something that we'd have to look to the oncologist to clarify. All right. And we note that any increase in the risk of breast cancer, again, is related to duration of treatment. And so we're going to use this hormone replacement therapy for the shortest period of time. Again, the hormone replacement therapy, when you consider whether it's used orally, systemically, or transdermally, is not associated with the risk of type 2 diabetes. And the evidence to suggest that the likelihood of hormone replacement therapy affecting cognitive decline at this point is unknown and would require further study. So finally, when we look at monitoring of these patients, should you choose to use hormone replacement therapy, again, at the lowest dose for the shortest period of time, it works well for a well-chosen patient. It's important to discuss the importance of keeping up to date, not just with taking your meds, but what else do you need to do as per the national recommendations to keep you healthy. So it's important to have an open discussion with our patients. You can't just take the medication, but there are other things that you need to do to maintain health, and I will mention those shortly. It is important to review your patients initially, maybe every 3 or so months, or at least that's 3 months after the treatment has been started, to see if it's well tolerated, as well as to see if it's working. And then afterwards, you can review your patients annually. You can go back to your annual reviews, and at that time, you can adjust the treatment based on any clinical indications or adverse effects. So when and why do you stop this hormone therapy? Remember, again, the shortest duration. So if you can stop it at that 5-year period or before, that would be perfect. And if you're going to stop the therapy, it's important to gradually reduce the dose so that the patient can acclimatize to the changes, because in reducing the dose, we can expect a recurrence of symptoms. Okay. So it's important to have that conversation with the patients. It's also important to talk to your patients about unscheduled vaginal bleeding. This is something that can occur with the commencement of hormone replacement therapy, especially within the first 3 months. But if it continues to occur, especially beyond that first 3 months, that is important that some investigations be done. And it's also important to be cautious in using hormone replacement therapy, or even to avoid hormone replacement therapy in women with a history of breast cancer or thromboembolic disease. Now, I thought I would put it in this routine wellness timeline just to remind us that when we're seeing our patients, it's just a matter of progressing from stage to stage to stage in life, that menopause is not a death sentence. Menopause is not a disease. And so we simply counsel and we adjust what we need to do. We adjust our advice as our patients age. And so just to remind us that, you know, in addition to the routine investigations that are required for for all our female patients, the kidney, the liver test, your CBC, your cholesterol, your sugar, your thyroid, that also at this age, we would also need to include your mammography, your colon cancer screening, definitely by the age of 40, that should have been started, and your bone density scanning as well. It's also important to talk to these patients about the entire self-care process. It's not only about the wellness visits and the screening, it's also about making the healthiest choices, the healthiest lifestyle choices, as well as to take the hopefully to take the physician's advice with the appropriate interventions that have been proven by rigorous studies. So I just want to say that, just to remind us that as we talk to our patients, we have to encourage them to eat healthy, to exercise, to keep up to date with their immunizations. As they age, you would want to advise them to have the pneumococcal vaccine at the age of 65. Avoidances such as smoking and caffeine, these are all detrimental to bone health. Advise them to adhere to any targeted interventions that you might have suggested, whether it be medications for pressure or sugar, cholesterol, or aspirin for heart disease. And it's all about awareness. The more you talk to your patients, the more they understand their health, the more they understand and appreciate that menopause is a consequence of aging and it's not a disease, then these women will be self-empowered to do everything that they could do to maintain good health. And so we've come to the end of our presentation. And I thought that I would end by just asking some very, very basic med student questions. So who's going to open their mic and tell me what is menopause? Please don't let me have to repeat. Who's brave to open their mic?
I think someone has opened their mic, Dr. Griffith.
Go ahead. Okay, I can't see the chat.
Okay, I can see the chat. I believe it's because Yui has opened everyone's mic. So we are waiting on someone to volunteer.
So
I'll volunteer.
yes, Michaela.
Good morning.
Good morning.
So menstruation is this complete sensation of the menstrual cycle for a period of 12 months.
Okay, good try. So it's defined as the cessation of the menstrual cycle, and you can say that you have indeed reached that phase when a period of 12 months of amenorrhea has occurred. Excellent. How many stages are there to menopause? Anyone?
There are 3 stages.
Okay, let me hear the 3 stages, Brittany. I lost Brittany. So remember we spoke about the menopausal transition, early and late, and then we spoke about the postmenopausal time span. Early postmenopause is within 5 years after that last menstrual period, and the late postmenopause is anytime from that 5th year time point to death. So the most common symptom of menopause is, I know everybody knows this one. No, the most common symptom of menopause is?
Hot flushes.
Hot flushes, wonderful. Wonderful. And true or false, hormone replacement therapy is used as long as required or as long as we feel like?
False. Shortest period of time.
Shortest period of time. Wonderful. And can anyone remember any one of the alternative or complementary interventions that I spoke about that were not FDA approved?
Gabapentin.
Well, that is actually FDA approved.
Tamoxifen.
Tamoxifen, well, is not used. What about the botanicals? What about the herbs? What about the soy? Yeah, no. The black cohosh. Remember, our patients are going to come and they're going to be telling us that, Doc, I purchased this from this wellness center, or I purchased this from here. What do you think about it? So we really have to be able to actually look at these products and have an open discussion with them. So I want to thank you all for being here with me this morning and for listening and for taking a whole hour out of your Friday morning to just sit and listen to me talk about menopause. Do you have any questions?
So thank you very, very much, Dr. Griffith-Bowe, for that really excellent presentation. You know, menopause is one of those things that we don't often talk about, and we often don't even think about it as we see our patients. And I see Dr. Bodie Williams is also saying, thank you for a very excellent and detailed presentation. So it is 9 o'clock and we will leave a few minutes for questions. And if there are any questions, you could place them in the chat. If not, and you don't know how to get in touch with Dr. Griffith-Bowe, you can always contact me and I will share her contacts with you. I did have some questions, Dr. Griffith-Bowe, but you have answered every single one of them along the way in your presentation. So that
Okay.
was really wonderful. You know, one of my questions was in the woman with combination therapy, would there be bleeding, vaginal bleeding, breakthrough bleeding, which you addressed. You know, and one of my observations, which you also presented early on, is I often find around the time of menopause, women come in telling you that they've been to quite a few doctors, doctor shopping, because of all the different symptoms that they're experiencing. So I just want to encourage everyone to remember that when a woman comes in complaining of varied numbers of symptoms. I just have one question I want to ask you. Can you just quickly, briefly lay out for us how you decided to put a patient on hormone replacement therapy? The last patient you put on hormone replacement therapy, what was the trigger?
Right. So the last patient that I utilized hormone therapy for was complaining of the genitourinary complaints. And so she was very amenable to using vaginal estrogens. And so she has been using the vaginal estrogens for 2 years now. She has been inconsistent in using the vaginal estrogens, but she notes that literally a day or two after she would have used it, that she feels substantively better. She recently questioned me about the use of Osphena. However, when I did the research and was able to speak to her about the costs, then we simply went back to the vaginal estrogens. I have also another patient. This is now her 3rd year on oral estrogen therapy. She had a hysterectomy about 7 years ago, about 5 years ago. And so she's comfortably using estrogen, low dose estrogen therapy. And this is her 3rd year using such therapy. But of course, you know, having had a relationship, having developed a relationship with your patient, you feel a lot more comfortable sitting with them and having these conversations. It's very difficult to have this conversation with a patient that you have no relationship with, because you have to get deep down and messy into the things that they might not want to even speak about.
Yes, thank you so much. And we do have a question. Could you expound on the demographic disparity on reporting hot flushes? Okay,
so what we do know is that there is a racial and an ethnical disparity with respect to how the menopause is viewed and thus how the symptoms are reported. So I want to be very, very careful as I say this. So very few women volunteer that they're actually experiencing, at least very few women, I'll be clear, of my ethnicity volunteer that they're having these issues. However, I would note that more of my Caucasian clients are more comfortable having these discussions. It very well may be that this is a discussion that they might have had with their parents or their grandparents, or it might be something that was introduced to them in school. We talk a lot about the menstrual cycle. We talk a lot about our sexuality, but we talk very, very little about the menopause. When you think about it, we speak very, very little about the menopause. And so our patients aren't necessarily very comfortable. And so to address those biases, again, everything has to be addressed on an individual basis. It may not be appropriate to have those conversations when you're just meeting the patient, but perhaps you can have an introductory conversation with the patient, give them some literature, have them read it, and then have them come back so that when they feel more comfortable, that they're then able to open up and have this discussion. It's also important to think about perception, because sometimes persons think that there's no need to treat this because this is a natural phenomenon. So they could be sweating consistently every hour they're having these hot flushes, but because they view it as a natural progress in life, that it's not necessarily anything to treat, and they don't want to incur the risk of the medication. So you have to take all those things in consideration when counseling your patients.
Okay, well, thank you very much, Dr. Griffith-Bowe. There are some other questions, but we are at the 9:07 mark, so we need to, try and get off our meeting now, and I will share those questions with you, and you can respond to those that have answered it. Gina Sands asked if there are any recommendations for women with decreased libido, and Dr. Estelle Leville, thank you so much. Could you share reference studies since 1998? And so we can answer those offline as it's now 9:07. And thank you very much,
Thank
Dr.
you. Thank you
Griffith-Bowe,
very
for
much,
sharing with
Kamala.
us
I would
this
just
morning.
say testosterone for the decreased libido, but we can get into that, and you can invite me again and we can discuss it further.
Yes, we can. Absolutely.
And I will share the references.
Absolutely. And what I would like for the audience to know is that the meeting is recorded, so you have access to the meeting after the fact, and you could look at it again and go through some of the information that Dr. Griffith presented. As I said before, we're having challenges in 2022, so we may not be able to always offer CME credits for the meetings that we've done this year. Once I have a decision, I'll let you know. Moving forward in 2023, everything has been ironed out. We will be offering CMEs. So thank you again to our wonderful presenter, Dr. Griffith-Bowe, and thank you to Dr. Halliday, our one-man technical support team. We appreciate you so much, and I encourage all of you to register and attend Research Day, which starts at 1:30 today and goes on until tomorrow. So thank you, everyone. Have a wonderful day, and we will have a PMH CME presented next week, Friday, which is to introduce you to the Princess Margaret Hospital Academy. So for those of you that have not heard, please join us. Wonderful things are happening at Princess Margaret Hospital. Take care, everyone, and have a great day.
Thank you.